when I came in the room, because I'm going to have to touch her eyes and look at her conjunctiva. So also, can you look straight ahead and watch my skin? Oh.
My mental status is questionable.
How about can you do? Oh, okay. Very good. All right, now I'm going to take a look in her eyes. And so I just do everything from head to toe. If I forget anything, let me know. So I'm looking down at the conjunctiva, and it's nice and pink, but not red. So, of course, and you want to wear gloves too if you do that. But her eyes look like they're fine. She doesn't have pink eye. And you want to look at the eyes and make sure they're not yellow, and that would indicate whether or not she was journalist or something like that. So her eyes look good. Her eyes aren't yellow. We just take a quick glance at her ears to make sure, depending on, what's going on with your patient, that she's not bleeding or anything from her ears, so fine. Are you having any difficulty hearing or anything? No hearing aids? You just have that all. You try to move fast, so you want to open your mouth. Do you have any problems chewing? No. God, I'm sorry. That's not permitted in nursing. We don't chew on nurses, so chew on.
The other thing is missing teeth, loose teeth, broken teeth, anything like that.
So
I'm
You
the
have
type
tears that had eggs from a month ago underneath them.
I had eggs for lunch.
So you want to look in your mouth and you want to have them lick their tongue. You really want to look under the tongue and make sure they don't have that thrush mouth, white patches or anything around. Look at the top of the roof of the mouth, the sides of the cheek, because patients, they get yeast infections all the time and they get the thrush and the white, the candida all in the mouth. You're not having any soreness or tinnitus? Are you chewing okay? Any dentures? And you notice all that, no dentures, no chewing problems and things like that. Okay. Since she's sitting up, I'm also going to check for JVD. You know what that is, right? Okay, so, but you would have them at a 45-degree angle, actually, so not all the way up, and then turn your head to one side. Oh, she has no JVD. Oh, but she does on the other side. Ooh, heart failure. So, moving right along. Any tenderness? You might want to touch their head. Actually, you can touch your head. Do you have any tenderness anywhere? You're not really doing tonsils unless they're actually symptomatic. We don't do a real focused assessment, except upper level nurse practitioners, or then you could check for thyroid and all that. But if you happen to see a bulge that you think is significant, then you might want to fill it if the patient is actually having a cyst or a problem. Okay, but you want to take a look. When she already says she's not having any swallowing problems, and I don't see anything. You want to feel the head, any tenderness around your face, anything, and no jaw problems. So when you ask them if they have any problems chewing, you can see if they have that what do you call it? TMJ. Okay, and so now I want to work my way down.
Hands are cold.
She's got a warm heart though.
Yes.
Unlike yourself.
So if you want to feel the patient, you want to check for turgor, here or on the chest. You can check for turgor. Turgor's good. Capillary refill. Ooh, she's blue. Check for capillary refill. That's fine. Then I want you to squeeze my hand. Can you push, pull, okay? And so her grips are fine. She squeezed my hand. So now I'm going to check her pulses.
Notice how Phyllis is doing both sides simultaneously, because we're always comparing one side to the other.
Both pulses are equal, nothing different. If you're feeling 30 pulse over here and something different over here, then that's a serious problem. Okay, so temperature and pulses. Now, heart sounds, lung sounds, or which one do you want to do first? Now I'm doing the chest. I'll do lung sounds. And they're pretty much the same landmarks. We're going to do right over the scapula, right at the top. So this is right here. You want to listen. You want to tell her to take a deep breath. You want to listen right there. Okay. And then you're comparing lung sounds. So the same thing like with the pulses, you want to go from side to side. You don't want to do this and this and do this whole side. Then you only know about that whole side. But you're not comparing to both sides unless you go from here to here, right over there. You can feel the scapula right here, so you know you're right over it. And then you want to come down to the second intercostal space. Listen over there, and then come over here to the second intercostal space. And then come over here. Fourth, fifth, X point, herbs. And then come over here and listen. Tell her to take a deep breath. And then you want to come right under, and you can have the patient, if they're
That's pleasure. This is
this
business.
is Mary always comes to bed. I'm like,
That's you.
get it.
You can do this for them,
And
but
Another
not
thing you
you.
can do it is you can have the female move her
Move
breast
it.
tissue herself.
Or you can hit like right in this area, just push down. If you know,
She's pointing to the lower outer
Right
quadrant
here.
of the breast.
okay.
Okay, so I want to push up, and then I want to listen right there, the mid-axillary, not mid-axillary, clavicular, and then I want to listen there. Okay, and then I want to go over here and listen. So we got 6 places, and then I want to do 2 axillaries. So you want to go 1 up here, you want to go over here, listen, take a deep breath, listen over here. You're short of breath, let me know. Are you okay? And so you wanna do that, okay? And then you wanna go on the back, and you wanna do 8 places. We start up high. 1, 2, 3, 4, 5, 6, then lower, 7, 8.
And
And
if you guys
that's-
could just turn around and show us those points.
Here,
Okay,
so-
it's pretty
yeah.
up high, about here.
Follow the scapula.
Follow the scapula, go right over here. Then come down to about almost a second on the front, and then over, and then down, over, and then down, and then over here. Now remember, the bases come like this. The bases are really up under her arm. So when you come, you don't want to come down too far down here, and especially here, you don't want to come down too far because your lungs go like this. They come like this. So you want to go up here, and then you want to come down to about here. Actually, you're getting the bases over here on your when you do axillary.
And on the back, where you just along that,
You go like so. You
the
have the
sternum, not the sternum, but the
Scapula.
scapular blade,
Mm-hmm.
are you just on the inside of that?
yeah. So you have the 2 up here, and then you're going out like this.
Okay, along the scapula.
Yeah.
If you think of the fact that your rib cage,
Yeah,
rib
it goes-
cage, your
goes like
lungs are
this.
underneath your ribs, and the lungs don't fall below the rib cage
In the
unless there's
front.
pathology or illness. So if you feel the patient's ribs, then you know you need to feel a little bit higher and listen between the ribs. Does that make sense? Like my ribs end right here.
Right.
So
you
I
wanna
would probably
listen
listen
right
to
there.
the basis around
The
right
base
in
is
here.
right there. And then a little higher up if you're axillary, because they don't go that far down. They come up under your rib. Okay? Heart sounds pretty much the same, except you want to start at the second intercostal space. And then we call this, we want you to tell us what heart sound you're listening for, pulmonic, aortic.
Aortic.
Aortic. Oh,
No,
aortic.
Aortic, yeah.
Eight to man.
Yeah. That's what it said, aortic, pulmonic. Go ahead, right. And then you want to come down to Earth's point, which is about here, 4th, 5th, intercostal space. And then you want to come down, tricuspid is right about 6. And then you want to come right mid-clavicular, right under the last, up above the last rib here, and that is your mitral. Okay?
What I would say to you is that it's directly below the nipple. Now, if you got somebody with a lot of breast tissue, those breasts are falling or all over the place. But if you could figure out where that nipple should be. It's like right above the,
It's right here, you don't want to.
Right above that last rib there, and that
Yeah.
space there, then it's right above there, mid-clavicular, right below the nipple, right, you'll feel it right there, and that's your mitral. Okay? Okay, now we're belly time. So, we're going to listen for vowel sounds, and we're also going to check for tenderness, and we're also going to look at the belly, because sometimes you can just see hernias or scars, and you want to document that if they have a scar, or if they just had recent surgery. People forget they chart that the patient has surgery, and then there's another skin assessment and says, oh, skin is intact, but they forget the patient just had surgery. So the skin isn't intact. They actually have a wound. So you have to tell what's the condition of the wound. Is it dressing? You don't have to take the dressing off if it's on there just to say the dressing is dry and intact. But if the dressing is bloody, you want to describe it's bloody. If it's green, describe it's green. So anyway, you take a look and you make an assessment of the belly. Before you touch the belly, you want to do your bowel sounds, because if you touch, then you might stir up some bowel sounds, and we want to see what the bowel sounds are like without us stirring them up. So you want to start in the right lower quadrant. You want to work your way up.
I'm here for lunch.
Garlic, no.
You said all your words were slurring, so I thought maybe you had something to drink for lunch.
Oh, I hadn't gone that far. What's that, martini? Okay, so start in the right, work your way up, and then go up to the upper quadrant, and listen for vowel sounds, and go over it, from right to left, and then down. And you listen for a few seconds. And actually the belly is right there. People think the belly is down here, so you're actually listening to the intestinal bowel sounds, because if they have surgery and they're not having any bowel sounds, you don't know that, because there could be problems, okay? So then you listen, and she does have bowel sounds, and you want to ask her, do you have any tenderness? And you might, usually we teach people to touch for tender, you just don't pull. You actually do like a little round motion with one hand like this, because you could feel nodules, or if she had something else going there, a hernia or something, and then you could feel it, okay? No tenderness, and then you want it to sit up, and then you want them to sit up like that, so you can see if they have a hernia, because if they sit up without support, then you know, 3/4 of the way, then you can see if they have a hernia when the belly goes in. Okay? Does that make sense? Any questions?
What if their belly doesn't go in?
Have you seen any bulges or
You'll see them pop out.
If they have a hernia, now remember what a hernia is, a break in the muscle wall. So even if they have a big belly, and they have a hernia, you'll still be able to see it. Okay? So, now we did all that. Now we want to
About last bowel movement,
Oh, yeah, last bowel.
urination issues.
the last
color.
bowel movement, you want to know when they had it and what the was it. You weren't constipated, you know. And one thing I can't stand is people come in the room and they give the patient a stool softener or a laxative, and they never ask them if they had a bowel movement. And then later the patient says, you know, I've been having diarrhea all week. And they forget laxatives every morning routinely. Nobody asks them if they've had it. So you want to ask them the consistency, when was their last bowel movement, and any problems. If they're avoiding, then, you know, just kind of ask them, are you having any problems, any burning when you urinate? Is it yellow, normal, or, you know, things like that. Okay? of course, a lot of people have edema, so you wanna check for edema. And the normal way to check for edema is to push in, and you go over the, what did you say?
Calf,
The bone.
the calf bone.
Yeah, calf bone. You go over the bone and you push down, because that's where you really can detect the edema. So you push down and you work your way up. And no edema. And if they do have edema, if your fingerprint stays, then it's pitting, okay? So you want to check color, warm, and before one thing we don't do is we don't check, we ask people if they're having any calf pain before we start moving around the lower extremity. Actually, I actually found a patient that had a clot in her leg, and that was the first thing I asked her was she had pain in her leg, and she said, yeah. I said, sure enough, she did have a blood clot in her lower extremity, and it happened. So you want to make sure they don't have any pain in the lower extremities. You check for edema, no edema, color, no bruising, and then now I want to check for posterior tibial pulses. So I usually grab them like this, and you see where I'm grabbing right in that little groove there, right in that little groovy point. And then if I grab one of it, you want to feel both at the same time. So if you grab both and put your hand like this, and then just wait, and you can compare. You want to compare one side to the other. So you get that pulse, and you feel it, and you hold it. And so then you want to do the pedal dorsalis, and so you can check for that.
You got any tips for pedal pulses? Because those are always the hardest.
Those are hard.
Yeah,
The large toe, the big toe, the great toe, and the second toe, if you run your finger
straight up.
straight down and start feeling probably about 1 inch to 2 inches from the separation of the two toes, and then just keep working up.
And then mark it.
And then mark it. Yeah, if it's hard to
Mark it.
find.
If it's hard to find,
make
always,
it so you mark
yeah.
it.
So just grab a little Sharpie
Sharpie.
marker and just put an X where you found it, so that you give indication to the oncoming person when you're going to check it again, and that way it helps, because if it's not there, at least they have an indication of where it was, so that you have that landmark.
And if I can't feel a pulse, I have to get the Doppler. I have to know for sure whether the pulse is there. So I get the Doppler off the floor, and I do a little Doppler and find the pulse. And some people just have very, very faint pulses. That's why they're not in good health, They have very faint pulses. But I gotta know if it's there or not. That's the way I have to do it. So if you have to need a Doppler, let me know. We'll have to find one.
And then if they have pain in their calves, you don't want to make them do a push.
The push-pull.
You don't want to make them do the push-pull. So that's why you always ask, are you having any pain, numbness, or tingling in your calves, back of your legs, or anything like that? And if they say yes, then don't check the push.
Because you could
dislodge
break
a blood clot.
the clot. Okay? So now I checked the pedal pulses, so now I want you to push, and can you pull back? Good. It's nice. So,
And then capillary refill and toes as well.
yeah, and toes, capillary refill. Any questions?
So same thing if they say they have cramping in there?
Cramping could be another sign of something else, but still, if they have cramping, I would think that might be something significant to look into. Yeah.
Versus having them go ahead and push
You
it.
may want to
Right.
look
Yeah,
at their
I'm saying-
electrolytes and see if there's an issue with an electrolyte. You may want to investigate that
Further,
more.
definitely. It still could be a clot,
Right. I mean, because they may not say I have pain back there, but cramping in the back of the leg or
Yeah.
something
Yeah.
like that.
So periodic cramping
Cramping.
would be probably an electrolyte issue.
Mhm.
So, but constant pain, you don't want them to push at all.
Right.
Or
Yeah.
cramping
Or warm.
and pain with
Right.
movement means something else.
And warmth.
Yeah,
To
so
the
I would
edge.
check that out before I would do anything further. I get cramps because I'm lactose intolerant, so I don't drink milk. So I have to go. I know it's time for me to get them Tums out and get some calcium when I get the leg cramps. But might be that. So you might want to check their electrolytes, or but definitely check out things before you have moving your legs around.
When you have leg cramps, though, it's still okay to do the pushing and the pulling on the legs?
No, I can do
That's what
anything
I
until I
was
found out what was causing the leg cramps, yeah.
If you've identified that it's an electrolyte imbalance, that's one thing. What we're afraid of is the cramp caused by a vascular occlusion. In other words, there's a clot in one of the leg veins. Then by that movement of pushing and pulls, it could dislodge the clot. The clot could become an embolus and travel up to the lungs and cause a pulmonary embolism and death.
Because even, I mean, I had a cramp I just had one the other day and I woke up with it. I couldn't even move that muscle, so I was limping around. So if they say, you can't really tell the difference, but I knew it wasn't a blood clot. Every now and then I get them because I don't get enough calcium.
Me too.
But, you know.
I woke up last
So I
night,
know,
and
yeah.
that's why I had my
So that-
Greek
I must
yogurt
have
today.
caught it from you, because I had it